So let's talk about preliminary assessment for possible interstitial lung disease. You know, when we focus on the patient, we really take in several different aspects of what's going on. There has to be a clinical suspicion, and usually that gets triggered by an abnormal chest X-ray or CT scan. We're going to put that into context with the patient's history and physical, and some key elements in regards to that physical are going to be the presence or absence of Velcro crackles. The crackles are pretty much universally present in patients with a honeycomb pattern on their CT scan, which would be consistent with idiopathic pulmonary fibrosis. We tend to take a look at other physical aspects, such as the hands or rashes or imploring symptomatology that might reveal an underlying connective tissue disorder. And then I like to incorporate, in addition to pulmonary function tests, 6-minute walk testing. And the reason I do that is it's a wonderful functional assessment of the patient to see if there really is a VQ mismatch that results from whatever's going on in the lungs. And that gives us some idea of what the state of the patient is. So when we approach these patients, the simplified approach is really asking just a few straightforward questions. Always looking to see if there's a cause. If there is no cause, does it appear to be idiopathic pulmonary fibrosis? And of course, if neither one of those fits, then would a biopsy provide additional information that would help simplify what we think this might be? And that's important to recognize as well, because it's true that sometimes you can get a biopsy result that isn't actually going to add information to the case. And the reason for that is that the biopsy results can be pretty universal in a lot of different situations. It's important to remember that usual interstitial pneumonia is not definitive for IPF alone, and that we see that in other interstitial lung diseases as well. So what are the things that we consider in the workup in the patient with a suspected interstitial lung disease? Well, you know, as we do that history and physical, we're trying to pick up on things that will tell us if it's acute versus chronic. We're looking at the exposure history that the patient may have experienced, what hobbies they were engaged in, whether they had mold exposure from hot tubs or moldy basements. We look to see what their comorbidities look like, what constellation might be there that really helps direct us in one direction or another. Their medication history, could there be a drug toxicity that would lead to the process? Then we look for physical evidence of the autoimmune disease possibilities, as I kind of suggested earlier. So things like mechanic's hands or sclerodactyly, signs of arthritis. The spirometry and pulmonary function tests are really going to give us some indication of disease severity. They're not going to really indicate to us which one of the interstitial lung diseases are there on the whole. They really just tell us whether or not the process is restricted or not. Now, the lab work can be very helpful, and the reason is that the serologic testing for many of the connective tissue disorders would really provide strong antibody support for what we might suspect is an underlying connective tissue disease. And the high-resolution CT scan is probably our most powerful tool, and the reason is if we pick up a pattern of honeycombing, that's going to be very consistent with usual interstitial pneumonia. And as I kind of mentioned already, usual interstitial pneumonia, while not unique to IPF, is what you're going to see on a biopsy when you have that honeycombing. So it tells you that doing a biopsy isn't going to get you where you want to go. That's in contrast to when you consider possibilities like nonspecific interstitial pneumonia or hypersensitivity pneumonitis, where in HP you might see granulomas, and NSIP will really show you this diffuse pattern that looks like the whole lung was hit at once. So as I was just mentioning, the exposure history becomes very important. And the reason for that is we have to think of exposures as not just what's in the environment, but also drug toxicity. And so drug-induced interstitial lung disease is a big category that we will often see. And one of the great sites that I grew up with and continues to be an incredible resource is pneumotox.com, which lists almost every last possibility known to man as people put in new drugs as they evolve over time as having been associated with an underlying interstitial lung disease. And I would really advocate that that be used as a resource by clinicians when they see patients. So what is the diagnostic algorithm in these patients? Well, as I kind of suggested earlier, we have a suspected interstitial lung disease. The first step is a thorough history and physical. After that, the most powerful tool that we have is that high-resolution CT scan. And the reality is it's going to give us a diagnosis 60 to 80% of the time. You couple that to getting the serologies, and that'll really help point you towards a connective tissue disorder. And an HP panel will really help direct whether or not there are exposures to known molds and allergens that might lead down that particular path. From there, we really decide whether or not there's a UIP pattern on that CT scan. And if we have a high clinical suspicion for IPF, the diagnosis is done. If it's a low clinical suspicion for IPF, that's where we start to work up other possibilities, where we think about a VATS biopsy so that we can get a read on the slide that might point in directions other than IPF. Of course, we can be led down that path by the high-resolution CT scan to begin with if there's an inconsistent pattern, or if the pattern on the CT is suggestive of another diagnostic possibility. So how can we use that imaging? It turns out the imaging is pattern recognition, of course. And so the first question that we ask is it reticular or is it nodular? I can tell you that in medical school, I grew up with the term reticular nodular. Let me get that out of everybody's head. I try to break these down very desperately into either reticular or nodular because they tend to correlate with an interstitial pattern versus a granulomatous pattern. And it's incredibly rare to see a true film that is both reticular and nodular. It'll predominantly be one or the other. Of course, if it's interstitial, the next question is there ground glass representing an alveolitis? And then pattern recognition again, is it upper versus lower? Is it peripheral versus central? We put that all into context, and a good thoracic radiologist will be able to make a correct diagnosis 60 to 80% of the time. The pulmonary function testing is really a static measure of the level of restriction the patient is experiencing. And each part of it will give you a different piece of information. The total lung capacity really speaks to the total size of the lung. And what that helps you realize is the level of restriction. The forced vital capacity is a flow, and that flow should have an increased elastic recoil, and the air should be out faster. And what we often see in these restrictive cases that are interstitial is a preserved air flow, whereby the FEV1 will also be high, particularly relative to the FVC. And the DLCO, it's important to recognize, really gives you a different piece of information. It's giving you what the capillary beds look like and the alveolar destruction that you're seeing in this particular patient. Conversely, it could be a sign of underlying vascular disease or simple anemia. What's the utility of the lung biopsy? Well, again, it depends what you're looking for. If you think the disease is a granulomatous process or is airway-centric, then that's where the biopsy, where the instrument is going in the biopsy. And the yield can be very high. In sarcoid, for example, upwards of 90 to 95%. And that's why we think of this as having a varied diagnostic capability from anywhere from 38 to 79%. And often, it'll mitigate the need for an open lung or VATS biopsy. Obviously, when you get a biopsy, you want to avoid areas of burnt out lung. And then the BAL itself can be very useful for other possibilities, infectious possibilities. Things like pulmonary alveolar proteinosis and PI syndromes are easy to pick up on a BAL and help really guide the diagnosis. Well, one of the most important concepts when we look at these patients in their interstitial lung disease categories is really recognizing that we do not at this juncture have a molecular definition for this disease process. Rather, a multidisciplinary approach or agreement among the various disciplines as to what is going on is currently the gold standard for diagnosing IPF and, frankly, many of the other interstitial lung diseases. There was a terrific study done a few years ago where information was fed to clinicians in conjunction with radiologists and pathologists, and they simply discussed the cases both individually and then in concert to really ascertain their level of agreement. And it's pretty amazing because as you add information and you let people talk, the level of agreement really goes up. And you see that that level of agreement is highest among the academic community who are really going to have the greatest exposure. I can tell you there have been 2 other publications since that have basically said it's not the key is not that you're at an academic center. The key is that you see a high volume of these patients. And indeed, private practitioners who see large numbers of these patients have the exact same behavior as was in the study by Flaherty. All right, what about the impact of the multidisciplinary team? Well, it turns out that team does a terrific job of not only reclassifying patients, but doing it in such a way that it really matters for the eventual treatment of these patients by changing management. And that's the goal, right? The goal is to be able to fit these patients into the correct box so that we know how to best treat them. And when you send them to centers that do this multidisciplinary approach, they change a significant number of diagnoses in conjunction with ultimately changing their treatment patterns, either by eliminating such things as steroid and sparing agents, or actually starting them if they've decided that it's not an IPF diagnosis.